I'm going to get us started talking about GG, and then Alice is going to be talking through the self-care activities, and then that may take us to break, or I might come up and start talking about the mobility items, and then, as Tom mentioned, we'll have a break, and then I'll do the wrap-up. So, again, this is the section GG, and I believe Deb highlighted yesterday that there's many new items in this section, so there's some changes that we'll be going through broadly, and I'll go through some examples, both with some of the items that have been on the MDS since 2016, as well as the new items. So as with all of these presentations, the acronyms are listed at the beginning of these slides. There's also a list in your packet. The objectives for this section of the presentation are that we hope that after this presentation, you'll be able to articulate the intent of section GG, you'll be able to demonstrate a working knowledge of section GG, function, abilities, and goals, you'll be able to explain item definitions, and you'll be able to apply coding instructions to accurately code practice scenarios. So just in terms of overview, there's really three types of questions that we'll be covering. The first set of items relate to prior functioning. So there's aspects of functioning that are important in terms of the quality measure calculation that relate to the person's status prior to the current illness, exacerbation, or injury. And that would be immediately prior to the illness, exacerbation, or injury. So we'll be covering two sets of questions that relate to prior functioning. Second, many of the items are coded at admission and discharge, and they relate to the resident self-care and mobility performance. So those are the performance items, and that's where we'll spend a lot of the time today discussing those items and doing practice scenarios. And then third, there are goals that can be documented in the goals column for each of the self-care and mobility activities. So we'll cover that also today. So the admission and discharge self-care mobility items assess the resident's need for assistance with self-care and mobility activities. So as I go through Alice and I go through the material today, one of the things that we'll want to reinforce is how much help and what type of help is this resident needing to complete an activity. So we'll try and do that to kind of just ingrain that. So as I mentioned yesterday, and I believe this was a question that was generally brought up yesterday, the Skilled Nursing Facility Quality Reporting Program last year in rulemaking added 4 new quality measures, and they relate to measuring residents' functional outcomes. So those 4 measures meet the requirements of the IMPACT Act, the Improving Medicare Post-Acute Care Transformation Act, which was passed in 2014. These quality measures specifically address the domain of functional status, cognitive function, and changes in function and cognitive function. These new quality measures use data elements that were already on the MDS, part of the process measure that you have been used to collecting data on. And so again, those items were added to section GG. So those are the performance items collected on admission discharge, and then the goal items. We have made some minor updates to definitions. So I'll go over that also today. So for example, eating as one quick example. After implementation, we had a lot of questions that came in from the help desk, from long-term care hospitals, skilled nursing facilities, and as well as inpatient rehab facilities, because all of those settings are now currently using some of these section GG items. And so one of the questions that we got was, well, does eating actually include liquids as well as solid foods? And the answer is yes. And so we wanted to be sure that we facilitated accurate data collection. Tom mentioned the importance of accurate data collection, as well as CMS mentioned that yesterday. And so we thought it would be helpful to make sure that was part of the definition on the actual data sets. So for all of the 2018 data sets, if you look at the definition of eating, it now includes liquids on MDS, as well as the inpatient rehab facility patient assessment instrument and the LTAC care data set. So it does not affect coding. So you would code exactly as you did. It was always the intent to include liquids, but we just thought it was really important to kind of reinforce some of these things on the actual data set. So we'll be covering some of those, and I'll explain a little bit of the rationale so that everybody's understanding kind of why some of the wording sometimes got changed and clarify some points that came up on Help Desk. And I do, by the way, really appreciate all of the Help Desk questions that have come in over the years. It helps us a lot to make sure that we're providing education that's helpful for you in terms of coding. And so some of the questions that, scenarios that Alice and I will be going over today are inspired by some of the questions that you've submitted to us, whether it was inpatient rehab facilities, skilled nursing facilities, or long-term care hospitals. There's been some common themes, and so we thought those were important to pull into these. In terms of the functional outcome measures, as I mentioned, these relate also to standardized data elements across the post-acute care settings, and I think my points that I just mentioned reinforce that. And these are, I think I mentioned this yesterday, the 4 quality measures are similar but modified from the quality measures used in inpatient rehab facilities. So they're not exactly the same. We did a lot of work to try and align the measures as much as appropriate, but when there are differences in the patient populations, for example, in inpatient rehab facilities and skilled nursing facilities, we found sometimes different risk adjusters, and so we used the data to inform our decision-making on risk adjustment. Okay, so the 4 functional outcome measures are listed here, as I mentioned yesterday. One relates to change in self-care ability. One relates to change in mobility. Another one reflects the person's status at the point of discharge for self-care. And the 4th one relates to the person's status in mobility at discharge. So the intent of this section, so functional status is assessed based on need for assistance when performing the self-care and mobility activities that we'll be discussing today. Residents in skilled nursing facilities have self-care and mobility limitations, and it's important to help address the assessment because the residents are also at risk for further decline in functioning due to their conditions or perhaps being in a skilled nursing facility environment and not their own environment where they would, excuse me, where they would be able to get up and move around more independently. So as was mentioned yesterday, the assessment where the data are initially collected is the Part A PPS admission assessment. So this is the 5-day PPS assessment where A0310B is equal to 1, and this is the first Medicare required assessment to be completed when a resident is admitted for a SNF Part A stay. This functional assessment must be completed within the first 3 days, and that means 3 calendar days. So if somebody was admitted today, they would have the balance of today plus tomorrow, the day after tomorrow, ending at midnight the day after tomorrow. So at 11:59, I guess, officially on day 3. In terms of the discharge, the Part A discharge assessment is required to be completed when the resident's Medicare Part A stay ends, and that's documented in either A24C, end of most recent Medicare stay, and that either would be a standalone assessment where the resident's Medicare Part A stay ends, but the resident remains in the building, or it may be combined with an OBRA discharge if the Medicare Part A stay ends on the day of or 1 day before the resident's discharge date, which would be documented in A2000. Just some general coding tips. Admission performance and discharge goals are coded on every admission assessment. So there's 1 column for each of the activities for the admission assessment. There's a 2nd column for goals. And that is regardless of length of stay or whether the person's stay ends in a planned or unplanned discharge. If the resident has an incomplete stay, so they are admitted and discharged prior to what was originally planned, you do need to complete the admission assessment and goals. The discharge self-care mobility items are not required if somebody has an incomplete stay, and so you do not see the section GG discharge items on the unplanned, if you're doing the unplanned discharge assessment. So the unplanned discharge is indicated by the type of discharge, so that's A0310G equals 2, that has a discharge date of in A2000, that is the most recent day or the day after the end of the most recent Medicare stay. Discharge to an acute care setting, or an acute care hospital, psychiatric long-term care hospital would be considered incomplete stay, or on the MDS discharge where A0310F is equal to 10 or 11, and the most recent date of the end of the stay reported in A2400C. Another example of an incomplete stay is in the event a resident passes away. And so a death would be recorded in A2100 where that is equal to 8. And so again, you will not see the section GG discharge items in that event. And also if the Medicare Part A stay is less than 3 days, then you would basically not see the discharge items in that case. Okay, so now I want to highlight the changes to the data set. So as I mentioned, prior functioning, there's 2 new sets of items, GG0100, GG110. I also want to highlight there's actually a new code with the new items that are being added, for example, car transfers or uneven surfaces. It's possible that you're unable to do an assessment because you do not have equipment or there's weather constraints, so walking on uneven surfaces, sometimes facilities will take residents or patients outside to walk on grass or gravel as an example of uneven surface. And so if that's the practice and there's weather constraints, you know, I live in Chicago, sometimes it snows. So there's a code 10 that can be used for that. And then car transfers, some facilities may not be able to access a car in their facility, and perhaps the resident's family is not able to visit with their car, and so there's not an opportunity to practice with the resident getting in and out of the car. And so again, code 10 can be used in those instances. One of the other changes that was made based on feedback from the post-acute care settings was there was interest in using the activity not attempted codes as goals. So if you're used to the MDS right now, in terms of goals, you can only enter the 01 through 06 codes as goals, but we were asked to consider allowing other codes to be entered. So the 07, resident refused, 09, activity not attempted, and it was not done prior to the current event, the new code 10, 88, activity not attempted due to medical condition or safety concern. So we do allow those as goals starting in October. And that applies actually not only to the MDS, but also the other settings. The other issue that came up as we were reviewing all of the definitions, it was brought to our attention that some of the activity definitions included the word safely, others did not. The overall intent, obviously, is that residents would be completing all the activities safely. If it's not safe for a resident to perform an activity, then you would use the activity not attempted codes. And so for consistency, we actually removed the word safely because, again, it was inconsistent in some of the definitions, but not all. But again, the intent is that's part of the overall instructions, and so it wasn't necessary to repeat that. There was also, on help desk, we had a fair number of questions asking whether something like contact guard was included in level 4, and the answer is yes. And so again, we thought it would be best and clearest to add contact guard as part of the definition of 04, and so we have added that, and so you'll see that on the data set as well as your practice case study today if you look at the items. As I mentioned before, the eating diet definition was modified slightly just to highlight that this activity also includes liquids as well as solid foods. And so you'll notice that difference. Under oral hygiene, there was just a recommendation to reword it just in terms of ordering, and so it's basically revised in terms of if a resident has dentures, the ability to insert and remove dentures into and from the mouth and manage denture soaking and rinsing with use of the equipment. So again, as with all of these definitions, no change in coding, but just trying to clarify based on feedback. We also had some definition changes related to clarifications in the area of toileting hygiene. So if you remember correctly, on the current MDS, that item is on there, and the activity relates to managing clothing and doing hygiene when you're going to the bathroom, and when the resident's going to the bathroom. And so the definition was clarified to talk about it's occurring after voiding or having a bowel movement. I think we previously talked about using the toilet, trying to be maybe a little bit too polite, and so people said, well, what if the person is incontinent, or what if they use a bedpan? Can you still code this item? And the answer is yes, and so we wanted to clarify that. So we are a little bit more direct and say that it's managing clothing and hygiene before and after voiding or having a bowel movement. The next activity is sit to stand, and we just did a little bit of revision just in terms of the wording and talking about sitting in a chair, wheelchair, or on the side of the bed in terms of where the person would start that activity. And finally, a minor edit, but important for interoperability. You heard about interoperability yesterday. So we previously wrote wheelchair/scooter, and we were asked to split up wheelchair and/or scooter. So no difference, same intent, but for interoperability, that was done. Okay, so now getting to the items, finally. So the first new items are GGO 100, and this is prior functioning everyday activities. This is what it actually looks like on the data set, and so what you'll see is that on the right-hand side, there are different groups of activities: self-care, indoor mobility, that is ambulation, stairs, and functional cognition. And on the left side, you see the coding. So oftentimes, you won't have a lot of detail in terms of the person's ability immediately prior to the illness that occurred. So let's say somebody is being admitted after having an acute care stay where they, let's say, had surgery and became debilitated, and they have some underlying cardiac and respiratory issues going on. And so the question here relates to how the person's functioning was immediately prior to that current illness, exacerbation, or injury. So oftentimes it'll be immediately prior to when they were admitted to acute care. And again, this is important for risk adjustment. This data is often collected by therapists, but what we found when we were developing these items as part of the post-acute care payment reform demonstration, we found that people weren't documenting this in a standardized manner, but it was definitely something that therapists were asking the residents and their family members so that they could set appropriate goals for their stay and any rehabilitation goals that were being made. So this information is self-report from the resident or family, and so we kind of have a basic scale just to say whether the person was independent prior to the current illness, exacerbation, or injury, whether the person needed some help with one or more of the activities, whether the person was dependent, or in some cases you may not be able to get this information, and so it would be unknown, and then 9 is not applicable. So again, because this is self-report, we gave you the option of putting unknown. Please do not put a dash if you do not know. You can just write unknown. So again, you're coding these particular items and indicating whether the person needed help or not prior to the current illness, exacerbation, or injury. So mostly self-report. You can also look at the person's medical records perhaps that might be documented. Again, our experience has been that this has been documented by therapists often, but just not in the same manner. So independent refers to the resident was able to complete the activities by him or herself with or without a device, it doesn't matter. So even if somebody used, let's say, a walker for the mobility or they used a cane, that's totally fine. They can still be independent. It relates to human assistance. Code 2, if the person needed some help, and that would be partial assistance, maybe with one or more of the activities and self-care. Code 1, if the person is dependent, if the helper completed the activities for the resident or the assistance of 2 or more helpers was needed. 8 is unknown, and 9, again, is not applicable. So also in the area of prior functioning, so when you're asking about how independent the resident was prior to the current illness, exacerbation, or injury, we're also interested in any device use prior to the current illness, exacerbation, or injury. So there's a limited list here of mobility devices, and so those items, as you can see on the screen, relate to a manual wheelchair, a motorized wheelchair and or scooter, mechanical lift, a walker, perhaps the person used orthotics or prostheses, and then of course there's none of the above if none of those apply. So similar to the prior item, you would be asking the resident or family about prior device use. You'd be reviewing the resident's medical record perhaps to find out what might have been used prior to the acute care stay if that's where the person came from. And you only report devices and aids used immediately prior to the current illness, exacerbation, or injury. So again, it's a checkbox, and if none apply, then there is Z, which you can check to indicate none of the above. Okay, so with this, I am actually going to pass off to my colleague Alice Smith, and she will start to cover the self-care activities. She's an occupational therapist, so you're in good hands with her. And I will be back. Thank you.
Thanks, Ann. Thanks. For some of you, this is going to be a review. I'm actually wondering how many people have been using Section GG for quite some time now, about 2 years? And others, this is new. So for those of you for whom this is a review, it's always a good idea to review again. Very many of us who have been using these items for a very long time forget the actual coding definitions, so bear with. And for those folks who are new, I hope that this information is useful to you as we go into the self-care items. This is just a screenshot that shows the MDS. I know you can't read it. I always go everywhere with my MDS, including right up here on the stage. I won't go anywhere without it. Nevertheless, there are several new items on the MDS that we're going to talk about today and review those items that have been there since 2016. There are also several new mobility items on the MDS. Again, we're going to review those that have been on there since 2016, and we're going to talk about the new items that have been added, as Ann just described. Remember for section GG0130 and GG0170 that it is an assessment, and you want to assess the resident's self-care and mobility performance based on direct observation, the resident's self-report, and reports from clinicians, care staff, family, documented in the medical record during that 3-day assessment period. It is a 3-day assessment period. For those of you who remember all the lookbacks for all of the MDS items, remember GG is a 3-day assessment period. Also remember to allow the resident the time to perform the activity as long as they are safe. That's really important in the skilled nursing facility arena where we really do want to, maybe I shouldn't say, rush the resident through their activities of daily living, but we really do, in order to do this assessment, need to give the resident the time to perform the activity in order to code what their self-performance actually is. If helper assistance is required because the resident performance is unsafe or of poor quality, of course you're going to score amount based on the amount of assistance that the helper provided. For Section GD, a helper is defined as facility staff who are direct employees and facility contracted employees, for example, rehab staff and nursing agency staff. That shouldn't be anything new to you. The activities can be completed with or without assistive devices, as Ann mentioned, and use of the assistive device should not affect the coding of the activity at all. If the resident's self-care and mobility varies during the assessment period, record the resident's usual ability to perform the activity. That does tend to cause the most consternation on the part of all of the MDS coders is what is usual performance. Don't record the resident's most independent performance. Don't record the resident's most dependent performance. Code usual performance. Usual performance does require some degree of clinical judgment. That is the key piece of usual performance. There may be several opportunities to observe the resident performing activity, or there may only be one opportunity to observe the resident performing a particular activity. So you are going to need to use your clinical judgment. You also want to refer to facility, federal, and state policies and procedures to determine which SNF staff are capable and may complete the assessment. It doesn't have to be the MDS nurse always. It doesn't have to be the therapist always. It doesn't have to be the nurse always. Each facility determines who will code these items. And just make sure that you're in compliance with your facility, state, and federal requirements. So when do you code usual status? Usual status is coded at the start of the SNF PPS stay. The resident's functional status should be based on a clinical assessment of the resident's performance that occurs soon after the resident's admission. The admission function scores are designed to reflect the resident's admission baseline status prior to the benefit from therapeutic interventions. So what does that actually mean is prior to the benefit of therapeutic interventions? It doesn't mean before any therapy. It means before the resident has had the opportunity to benefit from any interventions. And that's a key point, right? It's something that's very important, and you make sure you don't want to withhold therapy while you're doing this functional assessment. You want to make sure that you're providing the appropriate level of care to your residents and observing their usual performance in the first 3 days of the stay. For discharge, you would do it at the end of the PPS stay, not at the end of therapy if the resident stays in the facility, but at the end of the PPS stay, and code the resident's discharge functional status based on a clinical assessment that occurs as close to the discharge as possible. For usual status, the resident's functional status can be impacted by the environment or situations encountered at the facility. Observe the resident's interaction with others in different locations and circumstances may be important for a comprehensive understanding of the resident's functional status. If the resident's status varies, record the usual ability to perform each activity. Don't record the best performance, don't record the worst performance. Instead, record the resident's usual performance. So for the coding instructions, Ann just went through some of them, but we'll code the resident's usual performance for each activity using that 6-point scale. Now, I, in addition to my MDS, carry my little cue card for my 6-point scale. I'm sorry, I need all of these personal tools. It doesn't mean that you need all those personal tools, but it helps me to remember what the coding instructions are. I grew up in the era of Section G, right? So for me, it's always a, what was that again moment, at which time I just kind of have to look up what's the answer. So I carry my MDS, but if I don't want to be flipping pages, I have my little, I'll call it my cue card. So you want to code 06 for independent, code 05 for setup or cleanup assistance, code 04 for supervision or touching assistance, which now includes contact guard, right? Code 03 for partial moderate assistance, code 02 for substantial maximal assistance, and code 01 for dependent. If the activity was not attempted during the 3-day assessment period, indicate the reason the activity was not attempted. And I'll review what Ann just said because, again, for me, I need all of the refreshers and reminders I can get. So code 07 for resident refused, code 09 not applicable. The resident did not attempt to perform the activity and did not perform this activity prior to the current illness, exacerbation, or injury. And you want a code 10, this is a new code, not attempted due to environmental limitations, for example, lack of equipment or weather concerns. Code 88 for not attempted due to medical conditions or safety concerns. So now we're going to walk through a little bit of an algorithm that was developed to help coders kind of determine what is the level of performance based on these codes to determine, well, I'm looking at my resident, and how do I actually go through making sure that I'm selecting the correct code? So let's start with some key questions, such as does the patient or resident, and for me, please forgive, I do intersperse patient and resident, so the slides show a little bit of resident and patient at times. So does the patient complete the activity by himself or herself with no assistance? Physical, verbal, nonverbal, cueing, setup, or cleanup? If the answer is yes, then you would code 06, independent. If the answer is no, you would move to the next question. Because now you want to know, well, what kind of assistance and how much does this resident need? So the next question you would ask yourself is, does the patient need only setup or cleanup assistance from one helper? If the answer is yes, you code 05, setup or cleanup assistance. If the answer is no, they may need a little more help, then you want to go down to the next question. Does the patient need only verbal or nonverbal cueing or touching, steadying, or contact guard assistance from one helper? If the answer is yes, you code 04, supervision or touching assistance. If the answer is no, they need a little more help than that, you go to the next question. Does the patient need physical assistance? For example, lifting, trunk support from one helper with helper providing less than half of the effort. If the answer is yes, you would code 03, partial or moderate assistance. If the answer is no, they need a little bit more help than that, you go to the next question. Does the patient need physical assistance, for example, lifting or trunk support from one helper with the helper providing more than half of the effort? If the answer to that is yes, then you'd code 02, substantial or maximal assistance. And if the answer is no, you go to the next. So the next question is, does the helper provide all of the effort? Or is the assistance of 2 or more helpers required to complete the activity? That's a key point in the coding for dependent, isn't it? The assistance of 2 or more helpers. If the answer is yes, then you would code dependent. Do you think that this is a helpful algorithm to go through to ask yourself these questions for how to determine what level of performance this resident needs? The other key point that I want to bring out here, excuse me, is when we're coding the level of performance is based on more than half or less than half. I remember back in 2016 when I said, well, what if it's half? And the answer is clinical judgment. You need to use your clinical judgment to determine whether the resident requires more than half of the effort or less than half of the effort. We also have these activity not attempted codes, which are very useful. Code 07, if the patient refused. You would code 09, not applicable, if the activity was not attempted and the patient or resident did not perform the activity prior to the current illness, exacerbation, or injury. You would code 10 if the activity was not attempted due to environmental limitations, for example, lack of equipment or weather constraints. And code 88 if the activity was not attempted due to medical conditions or safety concerns. So when observing the resident, you want to review the resident's medical record and interview staff and be familiar with the definitions of each activity. So on admission, when coding the usual performance and the resident's discharge goals, you also want to use a 6-point scale for one of the 4 activities were not attempted codes to identify the reason that the activity was not attempted. At the time of discharge, you're going to use the same 6-point scale or activity not attempted codes. Do not record the resident's best performance. Don't record the resident's worst performance, but rather code the resident's usual performance during the assessment period. I think I can say that in my sleep. Do not record the staff's assessment of the resident's potential to perform the activity. And if 2 or more helpers are required to assist the resident to complete the activity, code as 01 dependent. If the resident doesn't attempt the activity and a helper does not complete the activity for the resident during the entire assessment period, code the reason the activity was not attempted. And to clarify your own understanding of the resident's performance of an activity, you may need to ask probing questions of staff about the resident, beginning with the general and proceeding to more specific. And there are some examples of probing questions in the RAI manual. So let's start with the coding instructions for GG 0130 self-care performance on the 3-day assessment period. So we're going to be looking at the admission performance items. So for those of you for whom this is a review, it's a review with some little embellishments added. As Anne identified, there have been some new tweaks to some of these coding instructions. Eating is the ability to use suitable utensils to bring food and/or liquid to the mouth and swallow food and/or liquid once the meal is placed before the resident. So as Anne identified, we've added food and/or liquid. And you want to assess eating based on eating or drinking by mouth only. If the resident receives some nutrition by enteral or tube feeding or total parenteral nutrition, you want to code the eating item based on the amount of assistance the resident requires to eat and drink by mouth. Assistance with tube feeding or TPN is not considered when coding the eating item. And based on help desk questions, we have provided for you guidance that says, if the resident eats finger foods with his or her hands, code based on the assistance provided. So now I'm going to bring Anne up because we're going to go through some practice scenarios. For each of these items, we have, for eating, the dietary aide opens all of Mr. S's cartons and containers on his food tray before leaving the room. There are no safety concerns regarding Mr. S's ability to eat. Mr. S eats the food himself, bringing the food to his mouth, using appropriate utensils, and swallowing the food safely. How would you code GG 0130A, eating, and what's your rationale? So, take out your cell phones. Join us in coding GG 0130A. Would you code A, code 03, partial moderate assistance, code 04, supervision or touching assistance, code 05, setup or cleanup assistance, or code 88, not attempted due to medical condition or safety concerns?
So just to Alice and I thought it'd be good to tag team this. So just to reinforce the decision trees that Alice reviewed, the first thing that you'd think about is, does the person need assistance from a helper? And if the answer is yes, the next question you would ask is, does the person only need setup or cleanup from one person? What do you think? Okay, do we need to keep going down the decision tree, or are we kind of probably there? We're there. Okay, all right.
Sorry, I didn't see Slido. What did the audience actually vote? Oh, okay. Well, we now know the answer. I think that one was fairly easy, so we didn't really need Slido. And the correct answer is code 05, setup or cleanup assistance. And the rationale, of course, is because the helper provided setup assistance prior to the eating activity. So now let's take a look at the definition or coding instruction for oral hygiene. Oral hygiene is the ability to use suitable items to clean teeth, dentures if applicable, the ability to insert and remove dentures into and from the mouth, and manage denture soaking and rinsing with use of equipment. GG0130B, oral hygiene, was clarified, and it is the ability to insert and remove dentures into and from the mouth and manage denture soaking and rinsing with use of equipment. There were some tweaking word changes. The intent of the item has not changed. So in coding the practice scenario, we have Mrs. K, who suffered a stroke a few months ago that resulted in cognitive limitations. She brushes her teeth at the sink, but is unable to initiate the task on her own. The occupational therapist cues Ms. K to put toothpaste onto the toothbrush, brush all areas of her teeth, and rinse her mouth after brushing. The OT remains with Ms. K, providing verbal cues until she completes the task of brushing her teeth. How would you code GG0130B, oral hygiene, and what's your rationale?
Okay, so going to the decision trees, first question would ask is, does the person need assistance? And what's the answer there? Yes. So then the question would be, does the person only need setup or cleanup assistance? One helper? No? Okay, so we're moving down the decision tree. So then the question becomes, does the person need just supervision, verbal cueing, coaxing, touching assistance, or contact guard? What do you think? Okay, all right. So is Slido going to come up? The options, I'll let Alice read those off.
Thanks, Anne. So how would you code GG0130B on Slido, with Slido or without? Code A, 05, setup or cleanup. Code B, 04, supervision or touching assistance. Code C, 03, partial moderate assistance. Or code 2D, substantial maximal assistance. And the answer is B. I heard a lot of B's, a lot of buzzing. Code 04, supervision or touching assistance. And the rationale is because the helper provided verbal cues to assist the resident in completing the activity of brushing her teeth. GG0130C is toileting hygiene. Toileting hygiene is the ability to maintain perineal hygiene, adjust clothes before and after voiding, having a bowel movement, or if managing an ostomy, it includes wiping the opening, but not managing the equipment. As Anne mentioned, toileting hygiene has been clarified, and now the actual coding instruction says it is the ability to maintain perineal hygiene, adjust clothes before and after voiding or having a bowel movement. Toileting hygiene includes the task of managing undergarments, clothing, and incontinence product and performing perineal cleansing before and after having a bowel movement. It can take place before and after use of the toilet, commode, bedpan, or urinal. If the resident does not usually use undergarments, then assess the resident's need for assistance managing lower body clothing and perineal hygiene. If the resident has an indwelling urinary catheter and has bowel movements, code the toileting hygiene item based on the amount of assistance needed by the resident when moving his or her bowels. So we're ready for another practice scenario. We have Miss Q this time, who has a progressive neurological disease that affects her fine and gross motor coordination, balance, and activity tolerance. She wears a gown and underwear during the day. Ms. Q uses a bedside commode as she steadies herself in standing with one hand and initiates pulling down her underwear with the other hand, but needs assistance to complete this activity owing to her coordination impairment. After voiding, Ms. Q wipes her perineal area without assistance while sitting on the commode. When Ms. Q has a bowel movement, a CNA performs perineal hygiene as Ms. Q needs to steady herself with both hands to stand for this activity. Ms. Q is usually too fatigued at this point and requires full assistance to pull up her underwear. So how would you code GG0130C, toileting hygiene, and what's your rationale?
All right, so this is a lot more complicated than the other one, so we're going to walk through this one together too. So first of all, I should state that think about toileting hygiene relating to when somebody has a bowel movement separately from when somebody's voiding. So if there are differences between toileting hygiene when somebody voids versus toileting hygiene when somebody has a bowel movement, you take the lower score. So in this case, let's walk through what happened. So when it comes to bladder, so voiding, there's 3 tasks involved, as Alice said. Clothing management before. So in this case, the person was able to get started. So she did a little bit. So she got started. For bladder, she's able to cleanse herself. So she did the second task by herself. And then she was too fatigued, so the helper did the third task. So in that case, there's a little bit so the resident is doing some of the effort because she's doing part of that first task with the clothing. She's doing all the wiping. The helper is definitely helping. With bowel, there's actually more assistance. So that's actually our code is going to be based on toileting hygiene related to when this person has a bowel movement. So in this case, the resident got started with pulling her pants down. The helper did the cleansing. The helper pulled the pants back up. So let's go through the decision tree knowing that we're going to be on the bowel side of things. And so obviously the first question, did the person need help? Yes. Was it more than just supervision set up from one person? Yes. I'm telling you. And then we go into, is there just supervision or touching assistance, or is it more? More? Okay. And then the next question then would be, does the helper provide more than half of the effort? Okay. So that's actually going to pull us down to another level. So where do you think we are? I'm sorry? So, yeah, O2, right, because the patient, the resident is doing at least something in this case, right, both for bowel and for bladder, but bowel most importantly. So, okay, it looks like Slidey-O is out.
Okay. It looks like voting is pretty good, and I think the majority of folks have selected code 2. And code 2 is the correct answer. Great. And that's, as Anne indicated, and as you have all agreed, the helper provided more than half the effort needed for the resident to complete the activity of toileting hygiene. We're now into some new items, shower, bathe, self. And shower, bathe, self is the ability to bathe self, including washing, rinsing, and drying self, excluding washing of the back and hair, and does not include the transfer in and out of the tub or shower. Shower, bathe, self includes the ability to wash, rinse, and dry the face, upper and lower body, perineal area, and feet. It does not include washing, rinsing, or drying the back or hair, and doesn't include transferring in or out of the tub or shower. Assessment of shower, bathe, self can occur in the shower, in the bath, at the sink, or at the bedside, for example, a sponge bath. If the resident bathes him or herself and a helper sets up the materials for bathing and showering, of course, what would you code? Read it. 05, setup or cleanup assistance, right? If the resident cannot bathe his or her entire body because of a medical condition, then code shower, bathe, self based on the amount of assistance needed to complete the activity. So let's practice again with showering, bathe, self. Mr. J sits on a tub bench as he washes, rinses, and dries himself. A CNA stays with him to ensure his safety, as Mr. J has had incidences of losing his balance while sitting. The CNA also provides lifting assistance as Mr. J gets into and off the tub bench. How would you code GG0130E, shower bathe self? And what's your rationale?
All right, so one of the first things to think about is what's the definition? And one of the key things here that is important for you to pay attention is that last sentence about getting in and out of the tub. Did Alice mention that as being part of the definition? No. Okay, so we can ignore that. So basically, the focus should be that the certified nursing assistant stays with him to ensure safety and because he perhaps might lose his balance. So is a helper needed during the activity? Yes. Is there just set up or clean up assistance from one helper, or is it more? More. Okay, so is it supervision or physical assistance or touching assistance only from one helper? Okay, all right.
And we'll allow a few more votes to come in, but it looks like there's an overwhelming majority so far who've selected code 04, supervision or touching assistance. We ready for the answer? Code 04, supervision or touching assistance. And that's because the helper provides supervision as Mr. J washes, rinses, and dries himself. The transfer onto or off the tub bench is not considered when coding the shower bathe self activity. Another new code this year is upper body dressing, which is the ability to dress and undress above the waist, including fasteners if applicable. We're going to go right to the coding scenario, but before we do, let's remember that if the resident requires someone to retrieve their clothes from the dresser or closet, or put away their clothes or to the closet or dresser, that would be what? Setup or cleanup assistance. Fasteners and buttons, that's always a question that I had, is how do you code fasteners and buttons when somebody just needs help with that zipper or the top button of their pants or blouse buttons or shirt buttons? Is supervision or touching assistance? For dressing, elastic bandages, stockings, orthoses, prostheses are defined for this activity as a piece of clothing when determining the amount of assistance that the resident requires. And for upper body dressing, clothing may include, this is a hard one for me, a thoracolumbar sacral orthosis, or a TLSO, an abdominal binder, a back brace, an upper extremity stump sock or shrinker, a neck support, or a hand or arm prosthesis. And of course, a piece of clothing for the upper body, that would include a bra and undershirt, shirts of all kinds, t-shirts, button-down shirts, pullover shirts, sweatshirts, dresses, nightgowns, pajama tops, but a hospital gown is not considered in the dressing activity. So, in looking at upper body dressing and this coding scenario, let's look at Mr. K, who sustained a spinal cord injury that has affected both movement and strength in both upper extremities. He places his left hand into 1/3 of his sleeve of his shirt with much time and effort and is unable to continue the activity. A CNA then completes the remaining upper body dressing for Mr. K. How would you code GG0130F, upper body dressing, and what's your rationale?
All right, so going through the decision trees, does the resident need assistance from a helper? Yes. Does the resident only need setup or cleanup assistance from one helper, or is it more? Okay. Does the helper provide assistance such as supervision or verbal or cueing, or is it more? Is the helper doing less than half of the effort and the resident doing more than half of the effort with some listing, or is it more? Okay. Is the resident doing some of the effort and the helper is doing more than half of the effort? All right.
All right. Survey is pretty overwhelmingly in favor of coding 02, substantial maximal assistance. Now let's see what the real answer is. Substantial maximal assistance, C, code 02. We have some great coders in the room and out in webland. And the rationale is, of course, that Mr. K can perform a small portion of the activity in upper body dressing, but requires the assistance of a helper for more than half of the effort of upper body dressing. Now let's talk about lower body dressing. And lower body dressing is the ability to dress and undress below the waist, including fasteners, and does not include footwear. So for lower body dressing, that might include a knee brace, an elastic bandage, a lower extremity stump sock or shrinker, a lower limb prosthesis, and for lower body dressing, pieces of clothing are pretty obvious, but let's review. It's underwear. It would include incontinence briefs, slacks, shorts, capri pants, pajama bottoms, and did I say shorts? I think I said shorts. So how would you code, did we have the scenario? My coding assistant and technical assistant. Mrs. R has peripheral neuropathy in her upper and lower extremities. Each morning, Mrs. R needs assistance from a helper to place her lower limb into and take it out of, and in the jargon, don or doff, her lower limb prosthesis. She needs no assistance to put on and remove her underwear or slacks. So how would you code GG0130G, lower body dressing, and what's your rationale?
Okay, so applying, removing prosthesis or orthoses is considered almost like a piece of clothing. And so when you think about assistance being provided, you would just consider that as, yes, the assistance is being provided just like it was another piece of clothing. So the question we would ask, starting with those decision trees, does a person need assistance from a helper? Yes, right? And so then is it just setup or cleanup assistance, or is it more? Okay, and so then we would say, is it just supervision or touching, steadying assistance, or is it more? Is the patient resident doing more than half of the effort and the helper is doing less than half of the effort? Yeah, I would say so, because the helper is putting on the prosthesis, and then no assistance is needed when the resident is putting on underwear and slacks. So that's a lot of work, and so it's just the prosthesis that the helper is assisting with.
We once again have a pretty overwhelming coding for 03, partial moderate assistance. Interesting. And there we have the correct answer, code 03, partial moderate assistance. Nice work. And the helper performed less than half of the effort of lower body dressing with a prosthesis considered a piece of clothing. The helper lifts, holds, or supports Mrs. R's trunk or limbs, but provides less than half of the effort for the task of lower body dressing. In contrast, coding level 4, 04, supervision or touching assistance, is used if the helper would provide either verbal cues and/or touching, steadying assistance as the resident completes the activity. Let's go to GG0130H, again a new item, putting on, taking off footwear. Putting on, taking off footwear is the ability to put on or take off socks or shoes or other footwear that is appropriate for safe mobility, including fastening if applicable. So we'll go to a practice coding scenario for putting on, taking off footwear. Mr. M is undergoing rehab for right side upper and lower body weakness following a stroke. He's made significant progress towards his independence and will be discharged to home tomorrow. Mr. M wears an ankle-foot orthosis, AFO, that he puts on his foot and ankle after he puts on his socks, but before he puts on his shoes. He always places his AFO, socks, and shoes within easy reach of his bed. While sitting on the bed, he needs to bend over to put on and take off his AFO, socks, and shoes, and he occasionally loses his balance, requiring staff to place their hands on him to maintain his balance when performing the task. How would you code GG0130H, putting on, taking off footwear, and what's your rationale?
Okay, so is there a helper involved? Yes. Is it more than just setup, cleanup assistance? Does the one helper just provide touching, steadying, supervision, or cueing assistance?
Well, with a score of 98 or 99% for code B04, supervision or touching assistance, I'm not sure we need to wait for many more responses to that item. And the answer is code 04, supervision or touching assistance, because Mr. M puts on and takes off his AFO, socks, and shoes by himself. However, because of occasional loss of balance, he needs a helper to provide touching assistance when bending over. For self-care discharge goals, remember, as Anne indicated, you would code the self-care discharge goals on the admission PPS 5-day assessment. You would use the 6-point scale or activity not attempted codes to code the resident's discharge goals, or you may now, effective October 1st, use codes 07, 09, 10, or 88 to code discharge goals. For the SNF QRP, a minimum of one self-care or mobility goal must be coded. However, of course, you can choose more than one goal, either self-care or mobility. Use of a dash is permissible for any of the remaining self-care or mobility goals that were not coded, but now that you have the option to code 07, 09, 10, or 88, I would imagine dashing the discharge goals will be much more rare. Using the dash in the instance for discharge goals after you've coded at least one self-care or mobility item will not count against the annual payment update determination. Licensed clinicians can establish the resident's discharge goal at the time of admission based on the resident's prior medical condition, prior and current self-care and mobility status, discussions with the resident and family concerning discharge goals, professional standards of practice, expected treatments, the resident's motivation to improve, the anticipated length of stay, the resident's planned discharge setting, and home. And of course, we all know this from working in skilled nursing facilities, this is not new. Goals should be established as part of the resident's care plan. When coding discharge goals, the discharge goal can be higher than the resident's self-performance on admission if the clinician determines that the resident is expected to make gains in function by discharge. The discharge goal can be the same as the admission performance on the 5-day PPS assessment if the clinician and the resident determine that the resident is expected to maintain and not anticipated to progress to a higher level of function for an activity. The discharge goal can also be lower than the admission performance. If the clinician determines with a resident who has a progressive condition, and that condition is expected to rapidly decline, and the resident may be receiving skilled therapy that may slow the decline of function. So the discharge goal may indeed be lower than the admission performance score. I'm going to turn it over to Anne to go through the GG0170 mobility items. I want to thank you for your time in coding these scenarios. I hope that the decision tree was helpful to you to walk through the scenarios, to walk through the coding instructions, to review some of the items that you have done before, and to review or go through some of the new items that will be on the MDS effective October 1st, which I personally am very excited about.
Great, thank you so much, Alice. So we have about 10 minutes before the break, but Alice and I kind of planned that if we were at this point, that I would just keep going with mobility so that we could maybe have a bit of time for questions after the break. So again, moving on to mobility. So you have all the rating scale details that Alice provided to you for self-care that also apply for mobility. As you are familiar, the first column, when you look at the actual data set, the first column is for the admission performance. The second column is for goals. One of the things with mobility that you'll notice is that there are some follow-up questions in relation to wheelchair use. And so you'll see there's actually a third column that's highlighted in yellow here a little bit that relate to wheelchair use and type of wheelchair. So we'll go through those when we get there. So starting off with the first activity in mobility. So the first activity is roll left to right, and this is defined as the ability to roll left to right, the ability to roll from a lying position and roll onto the left side and right side and back onto the back of the bed. So there's just been some clarification with the wording here in terms of ending up back on the bed. And so there's no change in coding. Everything that would be coded now would be coded the exact same way. It's just clarification. So in terms of practice scenario for this particular item, roll left and right. So Mr. Z had a stroke that resulted in paralysis on his right side, and he is recovering from cardiac surgery. He requires the assistance of 2 certified nursing assistants when rolling on his right side and turning to lying on his back, and also when rolling onto his left side and returning to lying on his back. So in this particular instance, do you want me to go through the decision tree, or do you kind of know? Go through the decision tree? You know. Okay. So I will let you go ahead and code. Obviously, a key piece of information here is that there's 2 certified nursing assistants. So one of the options is that the resident in this instance would be coded as dependent, A, or 4, supervision touching assistance, 9, not applicable, meaning that the person didn't do it now and did not do it prior to the current illness, exacerbation, or injury, or 8, activity not attempted due to medical condition or safety concern. It looks like there is 100% coding dependent, so yes, you did not need me to go through the decision tree, so that is indeed correct. And so you will see the check mark up with the 1, and again, the rationale is that you have 2 helpers. I know one of the questions that sometimes has come in through help desk is if the resident is doing a bit of the effort, you know, your instructions are to code 2, but what if the person is doing a little bit of the effort and there's 2 people providing assistance? And it would be code 1 in that instance, and if you followed the decision tree, it would get you to that level 1, because we talk at each of the levels. I'm not sure if you noticed, but it's assistance from 1 helper with, you know, in the decision tree when I talked about the setup cleanup by 1 helper, and then level 2 is that the one helper is doing more than half of the effort, but it's just 1 helper. So if you have 2 people that are required to help 1 resident to perform 1 activity, it will be that level 1, and obviously you demonstrated you're aware of that coding. So the next activity is sit to lying. So sit to lying refers to the ability to move from sitting on the side of the bed to lying flat on the bed. So we have one example here to go through together. And so Mr. F has had a stroke about 2 weeks ago and is unable to sequence the necessary movements to complete the activity, so he has apraxia. He can maneuver himself when transitioning from sitting on the side of the bed to lying flat on the bed if the certified nursing assistants provide verbal instructions as to the steps needed to complete the task. So how would you score this particular gentleman, Mr. F, and what is your rationale? So the options are 5, setup, cleanup assistance, 4, supervision, 3, partial assistance, and 2, substantial maximal assistance. Just talking through the decision tree, so helper is needed, correct? More than setup, cleanup assistance, right? Okay, and so then we get into whether there's supervision or touching assistance. So I think we're there, and it looks like 97% of you coded 4. I do agree with that. And so you will see the check mark come up for 4, so that is correct. And the rationale, as you indicated with your responses, is that there's verbal cues being provided. So level 4 is coded whether somebody needs intermittent verbal cueing or constant verbal cueing and supervision. It would all be coded the same. So at this point, I'm getting the signal that it's time for break. And so there is a 15-minute break, and we will pick back up with the next activity when we come back from break. Thank you very much for your attention. Okay, so continuing on with the mobility activities. So we left off at lying to sitting on side of bed. And so this activity relates to the ability to move from lying on the back to sitting on the side of the bed with feet flat on the ground with no back support. Just some coding tips. So clinical judgment should be used to determine what is considered lying for a particular resident. We've had actually a lot of questions on help desk about this in the last couple of years. And so we just added some coded tips to the training manual and wanted to reinforce those in this slide deck. So if the resident's feet do not reach the floor upon lying to sitting, the clinician will determine if the bed height adjustment or a footstool is required. Back support refers to an object or person providing support for the resident's back. If bed mobility cannot be assessed because the degree to which the head of the bed must be elevated because of a medical condition, then code the bed mobility activities affected by lying as 88 not attempted due to medical condition safety concern. And the activities that would be affected are GGO 170A, roll left to right, because obviously the person would be in a lying position in that activity. GGO 170B, which is sit to lying, and GGO 170C, lying to sitting on side of bed. So we've had, as I said, a few questions over the years about instances where the person had to keep the head of their bed elevated, and so they were saying, how do we code these particular activities? So make your judgment that if the head of the bed is slightly elevated, that you can assess one or more of these activities. If you determine in your clinical judgment that the head of the bed has to be elevated so much that these activities cannot be assessed, feel free to code activity not attempted. Okay, so we do have a practice scenario for this particular example. So the example here is Ms. P. So Ms. P is being treated for sepsis and has multiple infected wounds on her lower extremities. Full assistance from a certified nursing assistant is needed to move Ms. P from a lying position to sitting on the side of her bed because she usually has pain in her lower extremities upon movement. So in this case, the person is unable to perform the activity due to pain. So you would just code it again based on the amount of assistance provided by a helper. So the reason that the helper is providing, whether it's pain or some paralysis or another reason, you would just code again based on the assistance that's needed. So in this case, it says that full assistance is needed to perform this activity of lying to sitting on the side of the bed. So I will let you enter your responses into Slido. And if you, so here is the poll. The options that you have are 4 supervision touching assistance, 3 partial moderate assistance, 2 partial maximal assistance, and 1 dependent. So just walking through the decision tree, obviously we're going to be at the bottom end. So you would code 2 substantial maximal assistance if the resident was performing some of the effort. In this case, the example, and if you're looking at your handout that's in your materials, because it's not on the slide anymore, you'll see that it says that full assistance is being provided. It does not say that the resident is helping at all with any of the activity. It says full assistance from the certified nursing assistant is needed. So in this case, most of you did code 1. looks like almost 200 of you, and I do agree with that response as code 1, the rationale being that the resident did not provide any assistance in this instance as it's described. Okay, the next activity in mobility is sit to stand. This refers to the ability to come to a standing position from sitting in a wheelchair, chair, or on the side of the bed. So our practice scenario here is about Ms. R. So Ms. R has severe rheumatoid arthritis and uses forearm crutches to ambulate. The certified nursing assistant brings Ms. R her crutches and helps her to stand at the side of the bed. The certified nursing assistants provide some lifting assistance to get Ms. R to a standing position, but provides less than half of the effort to complete the activity. So if we walk through the decision trees for this example, so a helper is required. Is it more than set up clean assistance from one helper? Yes. Is there only supervision, touching, or verbal cueing necessary, or is it more? Okay, is the resident providing more than half of the effort with some lifting and trunk support assistance from a helper, or is it more? Okay, it says in here that Ms. R, let's see, the certified nursing assistants provide some lifting assistance. So we know we're going to be a 3 or below, and it says the lifting assistance to get Ms. R to a standing position, and the helper provides less than half of the effort to complete the activity. So in this case, the resident is doing more than half of the effort, the helper providing less than half of the effort. So again, the partial moderate assistance would be code 3, or if the helper is doing more than half the effort, you would code 2 substantial maximal assistance. Option 1, dependent, is also an option, and 88, activity not attempted. Okay. Looks like we are close to about 200 people participating. So, okay. So it looked like most of you coded 3, and I do agree with that response. So again, in this instance, there was lifting assistance provided, so you know it's going to be a 3 or below. In this case, they told you in the example specifically that the patient was doing, well, I guess it said the helper was doing less than half the effort, so you know that the patient was doing more than half of the effort, and so that's why it's a 3. The next activity is chair to bed chair transfer, and this relates to getting in and out of bed. It could be getting into a chair or a wheelchair, depending on the resident's circumstances. Again, some coding tips that we have on the slides here that have also been added into the manual. So that relates to chair bed chair transfer begins with the resident sitting on a chair or wheelchair or sitting upright at the edge of the bed and returning to sitting in a chair or wheelchair or sitting on the side of the bed. So again, it can be bed into a wheelchair or bed into a chair. It could be a sit to stand pivot. It could be a transfer board transfer depending on the person's circumstances. If a mechanical lift is used to assist in transferring a resident or from the bed or chair, and 2 helpers are needed to assist because of using the mechanical lift, you would code 01 dependent, even if the resident assists with any part of the transfer. And again, that goes back to what I mentioned earlier when we were going over self-care with Alice, that if the resident is helping a little bit, but 2 helpers are needed, the decision tree will direct you to a level 1 because it's 2 helpers. Okay, so our example is a little bit longer. So again, if you'd like to look at the example and keep it in front of you, you can look at your handout. And this example is actually on page 3 of your handouts. So Mr. U has had his left lower leg amputated because of gangrene associated with his diabetes, and he has reduced sensation and strength in his right leg. He has not yet received his below-the-knee prosthesis, so Mr. Yu uses a transfer board for bed chair transfers. The therapist placed the transfer board under his buttock, and Mr. Yu then attempts to scoot from the bed onto the transfer board. Mr. Yu has reduced sensation in his hands and limited upper body strength, so he has diabetes, so that explains that circumstance. So the physical therapist assists him to scoot by lifting his trunk in a rocking motion as Mr. Yu scoots across the transfer board and into the wheelchair. So there's a lot going on there. So basically, the resident is doing some assistance. There's only one helper involved. So just to kind of clarify things, it does say overall the therapist provides more than half of the effort. So let's walk through the decision tree. So there's a helper, it's more than setup, it's more than touching, supervision. So then the question is, so there's lifting that's being done, so it's either a 3 or below. So you would code 3 if the resident was doing more than half of the effort. You would code a 2 if the resident was participating but the helper was providing more than half of the effort. You would code 1 if the resident was not providing any of the effort or if 2 or more helpers were assisting with the activity. So the options for coding, if you can enter those into your phone or computer in Slido, the options are 4, supervision touching assistance, 3, partial moderate assistance, 2, substantial maximal assistance, and 1, dependent. Okay, it looks like about 160 of you have put in your answers. I hope those of you online are also trying to enter your responses. And it looked like most of you were coding 2, and I do agree with that as a response. So the rationale here in the slide is that the helper provided more than half of the effort for the resident to complete the activity. Obviously, when you're back at your facilities, if you're the person doing the assessment, in this instance, the clinical judgment would be on your you would be using your clinical judgment to determine who's performing more than half of the effort in order to code an example like that. Okay, the next activity is toilet transfer. So that relates to getting on and off a toilet or commode. So it doesn't matter, again, if the person is using a toilet in the bathroom or if they have a bedside commode, the activity is still coded the same way. So we have an example here with the practice scenario. Mr. H has paraplegia incomplete, as well as pneumonia and a chronic respiratory condition. Mr. H prefers to use the bedside commode when moving his bowels, so we can still code him, even though it's a bedside commode. Due to his severe weakness, history of falls, and dependent transfer status, 2 certified nursing assistants help him during the toilet transfer. So I don't think I need to go to decision trees with you. I'll let you code that one on your own. So options are 05, setup or cleanup assistance, 4, supervision or touching assistance, 2, substantial maximal assistance, 1, dependent. So we tried to put a variety of examples in here, and so some of these are easier than others. Looks like almost 170 of you have coded so far, so I'll just give it another couple of seconds. And it looks like most people were coding level 1, which is correct because there's 2 helpers. So that is indeed the rationale for the code of 1. Okay, the next activity is a new one. This is car transfers. And certainly it is possible that you might be doing this on admission and discharge, but if it's not current practice and the person is, let's say, has a great deal of difficulty transferring onto a toilet, onto in and out of bed, you're probably not doing this on admission. And so you can certainly code this 88, activity not attempted due to medical condition or safety concern. Again, if somebody, a discharge, is going home. This is an important daily activity. I know sometimes not everybody has access to a car, so if you have any kind of simulator, that's fine to use. You would use your clinical judgment if it is a simulator of some type. I think we've had several questions over the years from inpatient rehab facilities who've been using this item for a couple of years about what actually could be used, so we leave that to your clinical judgment, but certainly car transfer simulators are fine to use. If you do not have anything in your facility, you can have the patient's family, significant others bring in their car and practice transferring in and out of the car, immediately before discharge, that kind of thing. This is, again, an important activity for many patients, whether they are driving or not. They still are getting in and out of friends' cars or taxi or, ride share. And so, again, important activity to assess. So car transfer relates to the ability to transfer in and out of the car or van. So whatever the person will be transferring in is ideally what you'd assess. And it relates to being on the passenger side, and it does not include the ability to open or close a door or fasten seat belt. It truly is just the transfer. So we do have a practice scenario for this. During her rehabilitation stay, Ms. N works with an occupational therapist on transfers in and out of the passenger side of the car. On the day before discharge, when performing car transfers, Ms. N requires verbal reminders for safety and touching assistance. The helper instructs her on strategic hand placement while Ms. N transitions to sitting in the car passenger seat. The therapist opens and closes the door. So again, one of the first things I'll reinforce is knowing the definition. So as I mentioned on the previous slide, the car transfer activity here does not include the ability to open and close the door or put a seatbelt on. So you can actually ignore that distracting last sentence because that was just put in as a distractor. And so basically your score for Mrs. N relates to her needing verbal reminders for safety and light touching assistance. The therapist specifically provides instructs her on strategic hand placement. So I will not go through decision tree with you. I think you probably got this one. So the answers that you can provide are 5 setup cleanup assistance, 4 supervision touching assistance, 2 substantial maximal assistance, or 1 dependent. I'll give just a couple more seconds. And by the way, as I said, we have this item has been on the inpatient rehab facility data set for a couple of years. We've had a lot of great questions come in, and so we've incorporated some of the coding tips that have come in from that setting into the training manual to help you to get on the ground running in good shape right from the get-go. I will also mention that we have had a few instances where help desk questions come in and basically the people who were being discharged actually fell when they were being discharged and transferring in and out of their cars. So again, this is a really important activity, even though it seems like it should be pretty straightforward. It's a lot harder, and family members don't always know how to do these things. And so I do think this is, again, an important activity before discharge. Okay, it looks like 100% of you coded correct. 04. So I will do the check marks, and I don't think I need to provide the rationale. Again, if you are interested in rationale, all of these will be posted after the training with all the answers and rationale available for you. Moving on to walking. So I think when Deb presented yesterday, she highlighted that the item H that you currently have, which is a gateway question asking about whether the resident walks, that item has actually been removed to reduce burden. And so the skip pattern associated with whether the person is walking or not actually is embedded in this item, walking 10 feet. So basically, if you code walking 10 feet with one of the activity not attempted codes, which would be 07, refused, 88, activity not attempted, the new code 10, although I'm not sure I can think of a reason you'd code 10 here, but, and then 88, which is probably a reason that would get coded a lot, activity not attempted due to medical condition or safety concern. So if you're coding any of those activity not attempted codes, that's basically equivalent to saying the person doesn't walk. And so again, one item, H, has been removed, and so this item actually triggers skip patterns instead of that item. So I hope that makes sense. So the logic that we have is that if you indicate walking 10 feet didn't occur because of, let's say, safety concerns or the person refused, then we will assume that the person's not walking the 50 feet with 2 turns or the 150 feet. So we have you skip out of those through the data set skip patterns. Okay, so this particular item is as it previously was in terms of walking 10 feet refers to, once standing, the ability to walk at least 10 feet in a room, corridor, or similar space. So again, transfers are handled separately. There's obviously the sit to stand item that we already covered. In this instance, it's truly once the person's in an upright position, is that person able to walk 10 feet? So again, if the admission performance is coded 7, 9, 10, or 88 on the admission assessment, you would skip over to 1 step. We do skip you to 1 step because even if somebody, let's say, is in a wheelchair, somebody can go up and down 1 curb in a wheelchair. So you don't actually skip out of stairs, you just skip past the walking items. So again, just to reinforce, section I, if you code 7, 9, 10, or 88, you would skip over to 1 step on the curb, and that allowed CMS to remove the H item on the admission and discharge assessment. So coding tips related to the walking items. Walking activities do not need to occur during 1 session. So as you know, there's several walking items, 10 feet, 50 feet with 2 turns, 150 feet. There's also a new item, walk 10 feet on uneven surfaces. Those can happen on different days, probably something like walking on uneven surfaces, perhaps even the longer distances in walking might only happen in therapy. And so it may be those happen, let's say, on day 2 or day 3. They may not happen on day 1. That's certainly fine. You do have, for all of the activities, that 3-day assessment. We know that there are many activities here, and certainly some of the self-care activities like eating, oral hygiene, those are going to happen on probably day 1, day 2, depending on how late they come in on day 1, but you're going to have multiple opportunities to observe somebody eating or doing oral hygiene. Something like walking on uneven surfaces is probably not something that you do on the first day. Hey, welcome to our sniff, let's try this out. Walking on uneven surfaces is an important activity, but again, probably done with the physical therapist. I know I live in Chicago. We would not want to discharge somebody to walk up and down Michigan Avenue without being kind of ready for some distractions along a sidewalk there. So again, if you are maybe assessing walk 10 feet because the person is getting up and going to the bathroom on day 1, day 2. You may be able to get the baseline during those first couple of days, but something like walking on uneven surfaces or walking 150 feet, you may be waiting until day 3 when the physical therapist might be doing the assessment of that activity due to the person's activity limitations. When coding, the walking items do not consider the resident's mobility performance using parallel bars. So in this instance, the rationale is that in therapy, somebody who's walking in parallel bars probably has some significant limitations. The parallel bars cannot be moved onto the nursing unit or anywhere else. So anything that's not portable, we wouldn't consider that to be the person being able to perform the activity of walking 10 feet if they need that much assistance and that kind of support. So in the case where somebody, let's say, walks let's say 5 feet or 10 feet, but is in the parallel bars, you would code activity not attempted, and it's probably due to medical condition or safety concern. We have a few items that relate to turning, and so we've had questions over the years about what is a turn. So a turn for the walking items as well as the wheelchair items that'll be coming up relates to 90-degree turns. So that's, a turn around a corner. And so I think in our examples, we talk about the person walking into their room as an example of a turn, and turning into the bathroom. So that could also be a 90-degree turn. Probably many physical therapists would, especially with somebody, let's say, who's had a stroke or a brain injury, they'd want to have the person practice turning to the left and turning to the right. But as far as the assessment items, we do not restrict that it has to be one to the left, one to the right. It can be two turns in any direction. So it could be 2 left turns, could be 2 right turns, it could be 1 left, 1 right turn. So we definitely want to be sure that that's being assessed in terms of making turns, but we don't make restrictions on which way the turns are. So again, 2 90-degree turns for the walking item and the wheelchair item, and the turns may be in the same direction or in different directions. So we have some practice scenarios, of course, for the walking items. So in this instance, we have Mr. L. So Mr. L has had bilateral amputation 3 years ago, and prior to the current admission, he used a wheelchair and did not walk. Currently, Mr. L does not use prosthetic devices and uses only a wheelchair for mobility. Mr. L's care plan includes fitting and use of bilateral lower extremity prostheses. So in this instance, we put this question in because we do get a fair number of questions about Code 9. And so I want to kind of walk through a little bit more about that code. So I think Alice did a great job of explaining it. So if a person does not perform an activity, and in this case it says he does not walk, so we know we're down to the activity not attempted codes. So the options are refusal, which is code 7. The new 10 code, so that doesn't relate here. 88 is activity not attempted due to medical condition or safety concern. Code 9 is used when the person does not perform the activity at the time of the assessment. So if it's admission, the person does not do it on admission. Plus, the person did not do it prior to the current illness, exacerbation, or injury. So in this instance, this gentleman was not walking. He's been using a wheelchair for a long time. The goal is that he would use prostheses. He would be walking by discharge, but at this point, he's not walking, and he was not walking prior to the current illness, exacerbation, or injury. And so that is what the definition of Code 9 is. So looks like 98% of you did Code 9 in this instance, and I would agree with that. So again, the rationale being that in this case, this gentleman did not perform the activity at the time of the assessment, and he did not do it prior to the current illness, exacerbation, or injury. So Code 9 could certainly be used potentially for a goal, although in this instance, it does say that he is going to get fitted for the use of bilateral prosthesis, and walking is a goal for him. So in this instance, I would not code it, but certainly somebody who did not have a goal of walking and would just be in a wheelchair, you could code 09 as a goal. I think that was when we did the IRF LTAC training recently, people did ask for examples of when you might use 09 or 07 or 10 as goals. Usually I would say patient refusal is not going to be a goal, but we certainly, there are circumstances, right? Yeah, it's possible. So it's accepted. 09 is possible. I just gave you an example, but probably not going to happen too often, but it could happen. So moving on to the next next item. So the next activity is walking 50 feet with 2 turns. As I said, there are some additional coding tips for each of pretty much each of the activities that are based on help desk, and those are in the manual. So walk 50 feet with 2 turns here relates to, again, the walking with the 2 90-degree turns. Mrs. L is unable to bear her full weight on her left leg as she walks 60 feet down the hall with her crutches and makes 2 turns. The certified nursing assistant supports her trunk and provides less than half of the effort. So how would you code this particular item? So if we walk through the decision tree, in this case, the person is, so she does meet the criteria of going at least 50 feet because she goes 60 feet. There is a person helping, so we know that she's not going to get coded 6. There's no mention of only setup or cleanup, so we know she's going to be lower than 5. The person, certified nursing assistant, is providing trunk support, so that's more than the touching supervision, so we're going down below level 4. And so it's either a 3, 2, or 1, and in this case it says that the helper provides less than half of the effort, and so that means the resident is performing more than half of the effort, and so the options for you to code are 4, supervision touching assistance, 3, partial moderate assistance, 2, substantial maximal assistance, and 1, dependent. All right, I'll give you another few seconds. Looks like about 160 of you have entered the codes. Those of you watching on the web, please feel free to answer your responses also. Okay, so it looks like most of you coded 03, and I do agree with that. So again, the helper provided less than half of the effort, and so the resident was performing more than half of the effort. The next walking item relates to walk 150 feet, and this relates to walking 150 feet in a corridor or similar space. As with the other items relating to walking, the person starts in an upright position, so the bed mobility transfer, all of that would happen and be coded separately. So in this case, we have an example that Mrs. D walks down the hall using her walker, and the certified nursing assistant usually needs to provide touching assistance as Ms. D, who intermittently loses her balance while she uses her walker. So I think I'll let you think through the decision tree. So again, it's touching assistance that's being provided. So the response options in this case are 04, supervision touching assistance, 03, moderate assistance, partial moderate assistance, 02, substantial maximal assistance, and 01, dependent. Okay. Looks like there are 99% of you who are coding 04, supervision touching assistance, and I do agree with that response. So there's a check mark. And again, the rationale is that touching assistance is being provided intermittently through the activity. And as I stated before, supervision, cueing, or any kind of supervision can be intermittent or constant. It's still coded the same way at a level 4. So the next activity is walking 10 feet on uneven surface. Again, many people who may need to, after discharge, walk down the street or walk down their driveway to get mail, they might be faced with a sloping driveway or walking on a sidewalk and must be able to navigate uneven surfaces. So if your institution has some kind of setup where they have an internal obstacle course, I know some facilities have those, that's perfectly fine to use. Other facilities will take the residents, patients outside to walk on grass or gravel as an example. So however this can be done. Again, we do have the option of that 10 code that was added to the data set in the event that you are unable to assess this activity because you do not have the equipment or perhaps inclement weather. So that was a popular help desk question for a little bit that we got from the inpatient rehab facilities who've been using this item since 2016. So walking 10 feet on uneven surface officially is defined as the ability to walk 10 feet on uneven or sloping surfaces, indoor or outdoor, such as turf or gravel. I will mention that this item was actually selected based on the International Classification of Functioning put out by the World Health Organization. Their definition includes ice. We decided not to put that in as an example, not something that I would want to practice on. When I'm just, getting out of a facility, wouldn't want my mother to be tested on that. So, but those are the things, though, that people do face in the community, and so this is kind of getting towards that area. Okay, so again, this item has been used in the inpatient rehab facility, so if you're familiar with the definition that has been used, we did modify it slightly to clarify that it could be indoor or outdoor, and we also added in turf as an example. So in this case, you're benefiting from the experience of inpatient rehab facilities who've been using these items and had questions, and so we clarified that it could be indoor or outdoor. Okay, so walking 10 feet on uneven surfaces, we do have another practice scenario. So Miss N has severe joint degenerative disease and is recovering from sepsis. Upon discharge, Mrs. N will need to be able to walk on uneven and sloping surfaces in her driveway, so I kind of mentioned that before. During her SNF stay, a physical therapist takes Miss N outside to walk on uneven surfaces. Mrs. N requires the therapist's weight-bearing assistance less than half of the time during walking to prevent Mrs. N from falling as she navigates walking 10 feet on uneven surface. So again, key part of what's happening here is that the therapist is providing weight-bearing assistance, and it is less than half of the time. So I'll let you think through those decision tree questions. There's obviously a helper needed. It's more than one helper providing setup or cleanup assistance. It's more than just touching. So it's going to be a 3 or below. So I'll let you decide. Is it 04, supervision or touching assistance, 03, partial moderate assistance, 2, substantial maximal assistance, 1, dependent. Okay, I'll just give you a minute. Okay, all right, we've got 198. Let's get up to 200. Okay, all right, so the options, 4, 3, 2, or 1, most of you coded 3. I do agree with that. And again, the rationale would be that there is weight-bearing assistance being provided, so it's more than touching, so it's definitely 3 or below. And then it said it was less than half of the time, so that was less than half of the effort. Okay, the next activity relates to going up and down one step or curb, and so it can be a curb that's being practiced on. If you don't have access to a curb, it can be going up and down one step. If it is going up and down one step, it could be with or without a railing, so whatever is appropriate for the resident to be assessed on. As I mentioned, going up and down a wheelchair is acceptable if that person is, maybe perhaps a younger person who maybe is on Medicare because of an old brain injury or spinal cord injury, and so the person may be able to go up and down a curb in their wheelchair, and you can certainly do the assessment. And so we actually use the wording ability to go up and down a curb as opposed to step up a curb in order to be open to that. Again, we do have a skip pattern here to try and reduce burden. So if the person is unable to go up and down a curb or one step, we do have a skip pattern that if you say that the person was not able to perform this activity, whether it's refusal or activity not applicable, 09, or the 10 is coded, or 8 88, indicating there's a medical concern or safety concern, you would actually skip over this one and go right to pick up object. So there's actually 3 items related to steps. So this first one, again, related to one step or curb. We have an example here. Mrs. Z has had a stroke. She must be able to step up and down one step to enter and exit her home. A physical therapist provides standby assistance as she uses her quad cane to support her balance in stepping up one step. The physical therapist performs steadying assistance as Ms. Z uses her cane for balance and steps up, down one step. So again, this talks about somebody who has obviously a goal to be able to go up and down at least one step. The assessment for stairs probably happening in therapy more than on the nursing unit. And so in this instance, we do have the physical therapist assessing this. Standby assistance means that somebody's washing over close by. So that would relate to our terminology of supervision. She uses a quad cane. So as with all the activities, the person can perform the activity with or without a device. It doesn't matter, just code based on the type of human assistance provided. So it says here that the physical therapist provides steadying assistance. So it's not lifting assistance, but steadying assistance. So you have the options of coding 04, supervision or touching assistance, 3, partial or moderate assistance, 2, substantial or maximal assistance, or 1, dependent. Okay. All right, looks like I'll give you a few more seconds. So we've got 182. So we're close to 200. So give you a second. Okay. All right, so it looks like most of you coded 04, and I do agree with that, supervision or touching assistance. And again, the rationale being that it is touching, steadying assistance being provided as the person goes up and down one step. So now we're moving on to the next step activity. This is 4 steps. So many homes have 4 to 6 steps, and so this is why this particular item was added to the data set. So this relates very simply to going up and down the 4 steps with or without a rail as appropriate for an assessment. We do have a skip pattern here. We will assume that if somebody is not able to go up and down 4 steps, that they're not able to go up and down the 12 steps, which is the next activity. So you skip over this one with the data submission specification, so you don't need to enter anything because it'll skip you over. And so then you would skip to the last activity. So 12 steps in this instance is the next activity. So again, relates to going up and down 12 steps with or without a rail. We do have a practice scenario here. Ms. Y is recovering from a stroke resulting in multiple issues and poor endurance. Ms. Y's home has 12 steps with a railing, and she needs to use these stairs to enter and exit her home. Her physical therapist uses a gait belt around her trunk and supports less than half of the effort as Ms. Y ascends and descends 12 stairs. So probably in most instances, 12 steps is going to be a hard activity for many of the residents that you work with, so you're probably in general going to see lower scores, even perhaps as the residents are being discharged. So in this instance, there's a gait belt involved, so that tells me that there's definitely concern about the person's safety and that assistance is important and for safety reasons. And so that relates to trunk support, probably if somebody is actually using the gait belt and holding the resident, Ms. Y, up as the person is going up and down the 12 steps. So basically it says here that the support is less than half of the effort. So in this case, the resident is performing more than half of the effort to go up and down 12 steps. And so I will let you put the answers in. I guess you got a preview there. Thank you. A quick preview. So the answers can be 05, setup cleanup assistance, 04, supervision touching assistance, 03, partial moderate assistance, 02, substantial maximal assistance. I will give you a minute to put your responses in. So we're at 193. Let's get up to 200. One more. Okay, great. Okay, so the correct response, as you may have seen in the preview, is 03, partial moderate assistance. I agree with what most of you coded. Again, the rationale being that the resident is doing more than half the effort, therefore the helper is doing less than half of the effort. The next activity relates to picking up an object. So I think the most important thing about this particular activity is that it is the ability to bend and stoop from a standing position. So in the event that you have a resident who has very poor balance and is unable to stand up for long periods, or you're probably not going to be coding this activity, there would probably be a safety concern. An individual who is in a wheelchair in terms of mobility, you would probably not be, well, you wouldn't be able to assess this activity because the person must be in an upright position, and the activity is basically, again, bending, stooping to pick up a small object, just like that, from a standing position. So it's a pretty hard activity. Again, may not be safe for many individuals to perform this activity, especially on admission, perhaps even by discharge. So you may be coding this activity not attempted due to medical concern or safety, code 88. That's certainly appropriate. The question I think that we get most commonly about this is whether somebody can actually use a reacher. Thank you. Sorry, I lost my monitor, so I just paused for a sec. But yes, thank you. A reacher can be used. So in the event that somebody uses a reacher, in order to be independent, the person must be able to access the reacher on their own. If a helper brings the reacher to the person, that would be setup or cleanup assistance. If somebody has to stay with the person, because even with the reacher, they're leaning over a little bit, you want to be sure if they have balance problems, they're going to be okay, then you would code the supervision in that case. So again, even if the person uses a reacher, they may not be independent if they require somebody to put the reacher within reach for them so they can reach their thing, their spoon, or whatever is being tested. I think the other thing that I'll say is that, this is an important activity. I know that when we had our expert panel and we're talking about this item, this is a hard item, but the experts on our panel thought it was an important activity because people do drop things and people do lean over and sometimes fall, and falls obviously are a major safety concern. This is an activity that is used in by many therapists to make sure that somebody is safe when they're picking up objects. So for example, I think it's the Berg Balance Scale includes this item or a similar item, and so it's very commonly assessed. Okay, so Ms. C is our practice case scenario person. So Ms. C recently has undergone a hip replacement. When she drops items, she uses a long-handled reacher that she has been using at home prior to admission. She is ready for discharge and can now ambulate with a walker without assistance. When she drops objects from her walker basket, she requires a certified nursing assistant to locate her handheld reacher and bring it to her in order for her to use it. She does not need assistance to pick up the object after the helper brings her the reacher. So let's say that the helper has walked away. So one of the distinguishing features of the setup cleanup level is that somebody is needed to help get the resident or patient ready to perform the actual activity by themselves, but that person can then walk away and they are not needed for supervision. So that's why that is a distinct level, because Basically, that means that somebody could have placed that reacher there, I don't know, an hour before the person really needed it. And so there's more flexibility in terms of the helper's assistance, because somebody can actually provide that setup or cleanup assistance well before or well after the activity. They don't have to be there right before the activity or during the activity. So that's kind of why setup, cleanup is distinct. And that applies to all of the activities. So, just thinking about somebody going home and eating. So if somebody for eating has to cut up meat or open containers, things like that, those things could happen. A significant other could help the person do those kind of preparatory things, open containers, whatever. That person couldn't go off to work, and the person who has the self-care limitations would be able to pull out their cereal or whatever from the refrigerator an hour later. And so again, it just is kind of more flexible. So that setup, cleanup assistance is kind of a distinct level. And this is, I think, the first example where we kind of focus on that. So I wanted to kind of talk through that kind of thinking. Again, all of the rating scale was built with the idea of different types and amount of assistance. And as you kind of think through the rating scale, 6 is independent, 5 is this setup, cleanup. And so there's just a little bit of help, but a lot of flexibility in terms of when that help happens. Level 4, somebody is there, somebody is needing to either give verbal or some touching assistance. So we combine those categories together, because if a helper is needed, it could be, the spouse who is 90 years old and couldn't do, lifting, but could do verbal or, reminders, or could do a little bit of touching. And then, so that's kind of one level 4, and then the level 3, gets to be more the lifting assistance. So again, the 90-year-old spouse is probably not doing that lifting. So that obviously can affect discharge planning a lot. And so the levels do really kind of scale down to more assistance being provided. Okay, so getting back to this example. So in this case, the certified nursing assistants had to give the reacher to the resident in order for the resident to use it. It sounds like the resident's an expert at using it. The person was using it beforehand, so there's no concern about assistance being needed, even if this was an admission. So code options are 6, 5, 4, and 3. Okay, let's try and get up to 200 people giving an answer here. Looks like 97% of you are coding 5. Okay. All right, 185. Those of you online, can you help us out to get to 200? Okay, there we go. Okay, so you coded it 05. I agree with that. Okay, and again, the rationale is this is setup or cleanup assistance. Okay, so now we get to the wheelchair and scooter. So in this case, this is an item that has been on the data set. I am one of the people who actually does look at the data and look at relationships between the items. And one of the things I'll say about this particular item, so it says, does the resident use a wheelchair and or scooter? So as I said before, previously it used to be wheelchair / scooter. Now we just have and or in between, so it's not different in terms of coding. There are a lot of, at a national level, there are a lot of people or residents being coded as 1, yes, wheelchair use. And I do want to be sure to clarify that when you code yes here, that means that the person is actually, in many instances, maybe not walking long distances. So the intent is that the person is using the wheelchair for mobility purposes and not just to, let's say, the family's taking them outside, and so you're, having the person use a wheelchair for transport purposes. So I think when you're coding that the person uses a wheelchair, think about, was the person using a wheelchair prior to the current illness, exacerbation, or injury? If they were using a wheelchair beforehand, then you would be coding, yes, they use a wheelchair, because they're probably still using a wheelchair. If somebody is learning how to self-mobilize in therapy, definitely code wheelchair. If the person is just using it to get to therapy or get to the cafeteria or whatever for safety reasons, policy, you probably don't need to code this. This is really intended for people who are going to be using wheelchair post-discharge in the community. So, maybe that'll help reduce burden a little bit. If you say no, you skip out of the wheelchair items. But the intent is that the person is learning how to use the wheelchair to self-mobilize, and they'll be using it post-discharge. So again, I know a lot of physical therapists do training related to wheelchair skills management. I know some facilities have obstacle courses for wheelchairs. And so, definitely those would be coded as the person using wheelchair because they're obviously learning skills there. But if it's just transport and they're just being pushed, you may not need to code the wheelchair items. And in looking at the data, I did find that there were many instances where it says the person used a wheelchair and then they got coded dependent for the 2 wheelchair distances. And then when I look at their walking ability, they're doing quite well. So I'm wondering if those patients or those residents maybe don't need to be coded that they use a wheelchair because it's really just for transport purposes. So I hope that makes sense. We do have a lot of new coding tips. We do specifically spell out, if it's about transport only, do not code that the person uses a wheelchair. So this is one of the coding tips. It's in the manual. If the resident uses a wheelchair for self-mobility and is not exclusively transported by others using a wheelchair, then the gateway wheelchair question, which is Q1 on admission, Q3 on discharge, does the resident use a wheelchair or scooter, is coded 1, yes. So again, the transport stuff is, I guess, what I'd like to be sure you think about there. So the first activity in the area of wheelchair relates to wheeling 50 feet with 2 turns. And this relates to once the person is seated in the wheelchair, because of course we've already talked about bed mobility and transferring in and out of chairs and wheelchairs and scooters before. So once the person is seated in the wheelchair or scooter, the ability to wheel at least 50 feet and make 2 turns. I talked before about the turns being 90-degree turns, so that applies here also. So we do have an example here. Once seated in a manual wheelchair, Ms. R wheels about 10 feet and asks the certified nursing assistant to push the wheelchair an additional 40 feet into her room and into her bathroom. So the turns are happening when she goes into her room and into her bathroom. So one of the things about wheelchair is that if somebody needs to go 50 feet, so it's maybe just arbitrary in this case, but if somebody needs to go 50 feet and the person has the endurance, let's say in this case, to go 10 feet, then is somebody else going to help go the balance of the distance? Yes. So in this case, codes, if somebody is being coded for a wheelchair, the wheelchair items can be coded even if the person goes a partial distance on their own, because somebody's going to help the rest of the way. A helper will be helping. A person, can be pushed, whether it's, a therapist or a nurse or certified nursing assistant. And so you can code all of the activities even if somebody goes a partial distance for wheelchair. I say that in contrast to walking, where if somebody can, let's say, only walk, 5 feet, we would say that the person did not meet the criteria for walking 10 feet, and I as a nurse or you as a therapist is not going to pick up that person and help them go the rest of the distance, so we don't have the full distance. So the activity was not completed for walking if the person can't go the full distance, but wheelchair is different because somebody can help the person go. So does that distinction make sense? Okay. So, so in this instance, the person goes 10 feet. The helper basically pushes the person 40 feet. So as you think through the decision tree, we know we're going to be in the lower end because the activity did occur. As I said, there's 50 feet that the person went in this instance. There was 2 turns, so that part of the activity did occur. And then the question is, 10 out of 40 is the helper doing more than half of the effort, or is the resident doing more than half of the effort? Because the resident is definitely doing some of the effort, so we know it's not going to be 1. So it's between a 2 or 3, and if you think that the resident is doing more than half of the effort by going 10 feet, you would code 3. If you think the helper is doing more than half of the effort, you would code a 2. So the options are 04, 03, 02, and 01. Okay, and I definitely gave you a lot of help there. Okay, it looks like we're at about 140 people. Okay. All right, great. So we're, I think, close to 200. So most of you coded 02, and I do agree with that response. So again, 10 feet out of 50 feet, the resident is doing less than half of the effort. Okay, there are follow-up questions for the 2 wheelchair items. So again, I'll reinforce that if the person is not learning how to use the wheelchair or won't be using wheelchair mobility skills post-discharge, you get to actually skip 4 boxes if you say no. So again, please do pay attention to whether it's just for transport purposes, and then you don't need to fill out these items. In the event that you are filling them out, the person is going 150 feet with 2 turns, we ask a follow-up question. So when that person was assessed going 50 feet with 2 turns, was the type of wheelchair or scooter used manual or motorized? And so 1 is manual and 2 is motorized. And I will highlight, I guess because it's on this slide, we do ask that question both after the 50 feet and the 150 feet, because it's very possible that somebody might be able to use a manual wheelchair for short distances, but used a scooter or a motorized wheelchair for a longer distance. And so we do have follow-up questions for both in case it's different. So the next activity is wheel 150 feet once seated in the wheelchair or scooter, the ability to wheel at least 150 feet in a corridor or similar. So again, the same as what we talked about before. So we don't have a coding scenario here. Okay, so at this point, I want to switch over to talk about goals. So again, we've been mainly focusing on the performance assessment. I think some of our examples related to admission, some of them related to discharge, but the coding is the same, whether you're doing admission or discharge. Obviously, residents are expected to improve in many instances between admission and discharge. The second column on the admission assessment, as Alice nicely covered earlier, relates to discharge goal. I know quite a few of you have had a lot of questions about goals, so I think in the next few minutes, Alice might be coming up and helping just to reinforce a lot of that. So Alice has been busy monitoring your questions that are being submitted, and so we did want to cover some of those before our lunch break today. But all the guidelines that Alice talked about that related to self-care goals also relate to the mobility goals. So oftentimes, maybe the therapist would be making the goals, and it would relate to the person's prior functioning, the person's medical conditions, comorbidities. There's a lot of clinical judgment. And so again, just code at least 1 goal or activity in self-care or mobility. All of the activities can be coded. So I think Alice is going to address that a little bit more when she comes up. So in terms of summary, again, the section GG item relates to the need for assistance with self-care and mobility activities. Knowledge of the resident's functional status prior to the current event can inform treatment goals, and so that's an important part of the functional assessment section at this point. So the prior functioning relate to what the person's status was immediately prior to the current illness, exacerbation, or injury. And I think I saw a few of you had questions about that when I was looking at Slido over the break. So I'll just mention here that the intent is for prior functioning immediately prior to the current illness, exacerbation, or injury. In most instances, people would be admitted to an acute care hospital and then perhaps come to the skilled nursing facility immediately, and so it would be immediately before that acute care stay. So, for example, somebody who is living in the community experiences a stroke, and so the person is admitted to acute care, and let's say then your skilled nursing facility, and so the prior functioning would relate to right before the person's stroke. If you have, let's say, a resident who, let's say, a year ago experienced a stroke, was in acute care, and then maybe it was a mild stroke, they went home after that, and so now, a year later, this person's had a second stroke and is admitted to acute care, then prior function would relate before the most recent acute care stay. I hope that helps to clarify what that means. If somebody had, I'll give one more example. So if somebody had had a stroke, let's say ended up in a nursing facility as a resident and then experienced another stroke, and so the prior functioning would be what their status was in the nursing facility right before their second stroke. So we do talk about prior illness, exacerbation, or injury in the instance that somebody has a progressive neurologic condition, for example, multiple sclerosis or Parkinson's disease. So there's probably something that triggered the person needing to be admitted to acute care, so that's kind of your marker, what was going on right before that happened. So the exacerbation, I think there's a little bit more clinical judgment, but the intent is to document that the person had functional limitations perhaps beforehand due to a prior illness or injury or some kind of chronic or progressive condition. As I said, we use those data to risk adjust. So the original work that we did in this area to develop the functional outcome measures, we're using the post-acute care payment reform demonstration data, and we found that prior functioning was a really important risk factor. And so that's why, again, it's being added to the data set. And again, just very important in terms of setting goals with the residents. The expectation for the goals is that they're co-created with the resident. I think the other thing that I wanted to mention about prior functioning that I saw come through on the Slido, there was a question about the devices and whether for prior functioning, if somebody uses more than one device, do you check more than one? Yes. The prior functioning devices check all that apply, and then of course you have the option of none. Somebody wrote an excellent question and noticed that cane was not listed as a device, so thank you for that question. So during the post-acute care payment reform demonstration, we did actually have cane listed as a device, and when we did the risk adjustment modeling, we found that that did not impact or did not predict functional outcomes, but the other devices did, the walker did, and so it seems that use of a walker is just not strong enough of a predictor, and so we, as part of the data set, only add items that are necessary to calculate and do the best risk adjustment as possible, and use of a cane prior to the current illness, exacerbation, injury did not actually impact the risk adjustment model, and so that's why it's not included. It certainly may be something that's documented, obviously very, very important, but it wasn't necessary to actually add to the data set. Okay, so let's see, I think Alice, do you want to maybe come up? So before we do the share the action plans and ideas, we have about 30 minutes before lunch. So during the break, Alice and I thought it'd be helpful to kind of review some of the questions that you've been submitting, because they're really great questions, and Alice and I thought it'd be really good to reinforce some of those things before lunch. I certainly know some of you may be needing to catch planes later today, so we're going to do just focused GG for a little bit, and we will come to share your action plans ideas at the end, but maybe we can take 10, 15 minutes to go through that. So do you want to stand up here, Alice? And
Actually, if you could give me 1 minute to confer.
All right, take it away, Alice.
Okay. I think several of the points that I wanted to reinforce when I met with you are addressed in some of the questions. There were some commonalities in some of the questions, so if yours is not actually recited today, please don't despair. We will get back to all of the questions that were asked at the conference. But one of the very first questions on the list is define major surgery. And that was from the discussion that you had yesterday. And generally, major surgery for item J2000 refers to a procedure that meets all of the following criteria. The resident was an inpatient in an acute care hospital for at least 1 day in the 100 days prior to admission to the skilled nursing facility. The resident had general anesthesia during the procedure, and the surgery carried some degree of risk to the resident's life or the potential for severe disability. Anne, is there anything you wanted to add? Okay. There were a couple of questions on major surgery. There was a question regarding slide 21 on the annual payment update threshold for resident 5. And I know that you're not seeing what slide 21 is. I had to go back and look at what slide 21 is. It was the great graphic on APU, and then there was one on the quality measure and the state calculation. Specifically, the question was related to the data. There was a resident number 5 where that assessment was identified as a 5-day PPS assessment with a dash. What wasn't on that slide, and the slide, as you may recall, was pretty crowded as it was, and it was one example, so it was difficult to get all of the components onto that particular slide. And the question was related to the discharge goal. Now remember that as long as one discharge goal is coded, that you may dash any of the remaining discharge goals. So the dash referred to on that slide was really related to an admission performance, or if none of the discharge goals were coded. In that case, then it would be a problem for your annual payment update. I hope that clarifies that slide a little bit, and I just wanted to make sure to get to that point. Casey, would you mind standing up for a minute? I just want to acknowledge CMS with this particular question and answer. And the question is related to the changes in preparation for the physician-driven payment model. The question was, when will the final rule be available? So the final rule did come out yesterday. I want to acknowledge all of the staff at CMS for their unending work in all of the efforts that they've made in getting that rule out. So enjoy, happy reading, everyone. Happy reading, happy studying, happy extracting, happy summarizing, and happy thinking through the future of these next several months. It will be a very exciting period in all of our lives. There was another question regarding a particular slide with respect to, does this mean that we now need to complete all of the goals instead of the ones we are required to complete currently? In respect to the goals, remember that you are required for the application function measure that you're currently completing. For that quality measure, you're required to complete at least one goal. You may dash the remaining goals, although you may complete other goals as well. You may code goals for all of the admission, performance, discharge goal items. Effective October 1st, as you may recall, we have several new admission performance and discharge performance items. For the goals associated with those, for the application measure that we currently have, and we're not referring now to the new measures for the outcome measures. Before that application measure, you may select from among all of the relevant goals. So you're not limited to just those items that are currently on the item set, but you may select a goal from any of the discharge goal items listed on the item set. Is that clear? Did I say that clearly, Ann?
Yeah, well, car transfer is a new item. If you decide car transfer is the goal you want to report, it's not on the current data set, it's on the new data set, October 1. You can code that, and that will count towards the goal that's required, the one goal that's required. So you can pick one of the new items. That's, I think, what Alice was trying to convey. So does that clarify? Yeah, so the measure, basically 2631 application of the LTAC, which requires collection of admission, discharge data. The admission and discharge functional assessment data remain the same, those selected items, so there's only 3 self-care items for that measure. One goal is still required, but CMS opened it up to any goal that's appropriate for that patient. So again, only one is required. The rest of the measure stays the same, but we wanted to be sure that you had all kinds of options for goals, given that there are these new activities that are listed. I do want to stress, and Alice, I think this is probably something that's on there, the questions that came in. So there is a new APU table, right, for the new data set. And so for the quality measure 2631, which you have been using, the process measure, which kind of got us into section GG, the admission, discharge, performance items are the same selected group, but with the functional outcome measures being added as new measures, all of the admission performance and all of the discharge performance items are required on that APU table. So car transfers, admission is required. It may be activity not attempted, totally fine. So do not dash the car transfer if it's not done, code the 88 or 09 or whatever. And then the discharge is required for all of the section GG items. And that relates to the functional outcome measures. So for toileting transfer, when you code that, you get credit for the process measure as well as the 2 self-care outcome measures. You're entering it once, but it counts for both. So does that help, or Alice will clarify?
Can I just see a show of hands if anybody needs clarification?
Yeah.
Do you need a microphone, or I can repeat the question? To repeat the question was with respect to the new outcome measures. Is it still a process measure, or is it related to outcome? Ann, I'm going to let you take that one.
Okay. So the measures that were added last year through rulemaking are outcome measures. So if you're interested in the process, I can certainly get into some of the details a little bit more, but basically you will be getting through your CASPER reports the average change in self-care, the average change in mobility. There will be observed or unadjusted data. So if you had a resident who came in and, let's say, when all the self-care activity scores are added together, I can talk a little bit more about process later on, but in general, if your self-care score, the way the QM users, quality measure QM users manual tells you to analyze the data, if you add up the scores and let's say the resident is 20 on admission and 40 by discharge, you would have a change in self-care of 20 self-care units. And we do have a risk adjustment approach that is detailed in the skilled nursing facility quality measure users manual, which I think will be posted fairly soon. So that spells out all the details of how it's collected, but we do a lot of risk adjustment. So for example, individuals who have limitations in prior functioning and self-care mobility, basically we expect them to have less functional improvement because of their prior limitations, and so we adjust that to make a risk-adjusted value. So we calculate an observed change in self-care, we calculate an expected change in self-care, and then we report basically a risk-adjusted value, and there'll be national comparison data. Okay, so to repeat the question, just so everybody heard, great follow-up question. So I mentioned that there's going to be a national score, and that's basically the benchmark. So what we do is we risk adjust each facility's self-care change data so that it's comparable to the national data. So we adjust your data so that you can compare what is happening nationally and what is happening in your facility, take into account the complexity of your patients.
And you get penalized if you're not performing well?
Okay, great follow-up question. Is there a penalty related to performance? No. No. So I think, Alice, the skilled nursing facility value-based purchasing is just readmissions? Is that right?
Yes. That's correct.
Yeah. Yeah, so basically for the functional outcome measures, you will get reports eventually. You know, obviously data collection starts later this year, so you will get feedback through confidential feedback reports in the CASPER system. I think in the rule, was there finalization of public reporting? So there was a proposal to finalize public reporting of the functional outcome measures. That was finalized yesterday at 4:15. So public reporting is kind of the direction. So there's no, with the current rule that got published yesterday, there's no penalty or anything related to the actual quality measure scores, but it will be publicly reported. And I do want to also, I guess I'll say, please do feel free to look at the quality measure user's manual, because we did have a lot of expert panels over time, and these measures have been basically, again, adopted from the inpatient rehab facility quality reporting program. So we've had many cross-setting expert panels. Actually, since, 2012, I think was the first panel. We've asked about, are there specific exclusion criteria that we should include? So for example, somebody who has an admission diagnosis of coma, or somebody who has an admission diagnosis of tetraplegia complete, we don't expect them to gain in the same way, or it's not as predictable in some cases. For example, somebody who's in a coma. So we do have exclusion criteria. So some patients or some residents are not included in the calculation. The other thing that's really important and relates back to the incomplete stay that I kind of talked about at the beginning, if a resident is admitted and there's an emergency situation where the person leaves, and so the stay is basically ended early, incomplete stays are, residents who have incomplete stays, their stays are excluded from the functional outcome measures, because there's other measures basically that pick up the readmission, and when we've talked to our expert panel, they felt like it was, in order to understand residents, patients' functional outcomes, you needed a complete post-acute care stay. So one, you're not doing a functional assessment if somebody's got a pulmonary embolism possible, right? Like, you are not going to worry about whether they're walking or eating. They need to get over to acute care. And so the functional assessment data is really hard to gather in those circumstances. And so it's not really fair to use that data that's difficult to gather and has been inconsistently gathered in the past. And so there's a lot of exclusion criteria. I can promise you a lot of thought has been put into this, but certainly we are always interested in your feedback to make the measures as good as they can be. The measures that, as I said, were adopted by CMS were put through the National Quality Forum, so we got a lot of feedback that way. That was basically in 2015. They're due to go back to NQF for re-endorsement. So we are looking at all the data. We look at, Alice was, I think, mentioning this also. We got a lot of help desk questions. We look at the data. And so some of our training examples relate to addressing some of the things that we've seen in the data and the help desk questions. So we're always trying to make the data as good as it can be, our risk adjustment models as good as they can be. I know Alice said she carries around the data sets. I carry around the risk adjustment models, so.
Nice compliment. There's a question at the microphone, and I guess if we're going to take open questions, if you wouldn't mind going to the microphone, just for the benefit of the audience, I would appreciate it. And I'm sure our technical crew would as well. Thank you.
Thank you, Alice. Question about the measure specifications for the process measure, which is care plan. That a care plan, admission data, functional data was collected, discharge, and a goal was set. So in the specifications for that, there are only 3 self-care items listed, and there's 4 being added in October. So if one of those 4 is the only goal that you set, will you still get credit for the process measure?
Yes.
Okay. So those specifications are going to be updated?
Yes.
Thank you.
Thank you so much. This is very definitely educational for us, and I know some of these questions are difficult, so kudos to you folks. My question is, you had mentioned the expected discharge component. Can you tell us what data that's based on? Does that utilize the facility-determined expected discharge goal, or how is that determined?
Great question. So I think if I'm understanding the expected score, how is that calculated?
Facility expected discharge.
So that's basically what we do is we look at each resident stay. We look at the characteristics of the patients on admission. We, first of all, apply exclusion criteria. So anybody who has an incomplete stay, for example, would be excluded from the analysis. We then apply regression coefficients from the national data. So I'm just going to make something up here. But let's say we find that people who have prior functioning and used a Hoyer lift. And so that's checked off. If our national data that is collected over, let's say, 9-month period or a year shows that on average individuals who had a Hoyer lift prior functioning have 1 less unit of mobility change or self-care change. Basically, we applied that as kind of, so it's algebra basically, and so we basically would expect in general on average individuals who used a Hoyer to have 1 less unit of GG self-care change or mobility change. And so we adjust it that way. Does that help?
Yes, so it's not the facility expected discharge score based on the goal. It's more of an algorithm, a CMS facility expected discharge score.
Correct. So the expected is based on national data, not on the goal.
Okay, thank you.
I can tell you that there's been TEPs in the past about whether goals should be used, and there was a decision and recommendation from expert panels not to use goals, but that's an excellent question.
Thank you.
Before we take the next question, I know that the QM User's Manual that includes all of these new measures is not yet published or posted. For those of you who have a burning desire to read the specifications that will be in the manual, there is information that came out with the FY18 PPS final rule last year that has all of the measure specifications, the technical specifications for the measure. So you may refer to that. They're posted on the QRP website under Measures and Technical Information on the Measures and Technical Information page. I find it to be extremely useful. Question?
All right. So for the mobility score, are you going to pool all the data together, or are you going to analyze patients who can walk separately from patients that can locomote with their wheelchair?
Great question. So at this point, the wheelchair mobility items are not part of the mobility score that are added together. We are definitely looking at the data all the time, but at this point, the wheelchair items are not integrated into the functional outcome measures. So those items being on the data set are right now only associated with the process measure, but we are looking to include those in the future.
Thank you.
Great question.
Thanks for those questions. That was great. We have some, I would say, more to the heart kinds of questions on coding rather than measure calculation. But I did want to mention one specific response to the question that was first asked that started our discussion on the quality measure. That is regarding the process measure versus the outcome measure. And just for clarification purposes, we did have some discussion yesterday on the difference between the quality measure score and the annual payment update. And I want to make sure that you do, in your mind, on paper and everywhere else, separate those two concepts between annual payment update and quality measure score. The quality measure score being based on stay and the annual payment update based on the completion of information. So to clarify the question and response to the question that was first asked, I think that may be an important component to just keep in mind. So going to one of the other questions, on toileting, if the resident wears briefs and did prior to stay, would coding 09 be correct? Well, that depends. I'm sorry. A little humor. For toilet hygiene, the activity includes perineal hygiene, adjusting clothes before and after voiding or having a bowel movement. So if the resident wore incontinence briefs prior to admission, it may be that the resident removed their briefs, changed their briefs, pulled up their briefs, pulled down their briefs, and still was continent for some portion of the voiding activity. So for toileting hygiene, you can't just automatically out of hand say that it applies or doesn't apply. And I just wanted to make that point as well with respect to that question. A question regarding GG0110, prior device use. Can you select more than one item? For those of you who took the sneak preview look at the item set, the answer is yes. You'll check all that apply. The question here is, can therapy complete GG0100 and GG0110? This is another one of those questions that I probably could recite in my sleep, and that is essentially that CMS does not dictate who can and cannot code the items on the MDS. That is according to facility, state, and federal policy. You just need to make sure that you realize that all of these items are assessment items, and you need to follow what your policies are for your individual state according to the requirements for assessments. Looks like we have a question.
Yes, I just have a follow-up question to the toileting issue. When you presented this scenario earlier, I was just wondering, when you consider toileting and it's the hygiene portion, plus you look at voiding and bowel movement, and the example that you had earlier, the resident was more independent in the parts of it, but real dependent in the bowel portion of it. When considering less than half of the helper helping with less than half or more than half, do we look at the whole toileting activity or the components of the toileting activity? In your example, the caregiver helped with more than half of one component of the total toileting activity. So how do we look at that for more than half, less than half?
Great question. So each time an activity occurs is an opportunity to do an assessment. So obviously people go to the bathroom multiple times a day. So in the event that somebody is allowed to be as independent as possible, so Alice talked about that early on before the break. So if in each instance, the resident was allowed to be as independent as possible. Each is an opportunity to code. And so we do say code the usual performance, and then we do have this special thing for toileting that if bladder and bowel are different, so when you code bladder, this is the code 3, let's say, and bowel is coded 2, you would default to what got recorded is the most dependent episode. So each episode that something happens can get coded as long as the person is allowed to be as independent as possible, and it's, an assessment, a clinical assessment, and then once you have an idea of how the person is doing overall, and again, in the instance of toileting, there's probably a lot of opportunities during a 3-day assessment period, and so you basically then look at kind of where the person is overall each time it happens, and in the instance where there's differences between bowel and bladder, you can take the most dependent episode. So does that help?
Yes, thank you.
I believe Anne answered this question during her presentation, but let's just review. Locomotion per wheelchair for transport. Is that self-performance? Now remember, for wheelchair mobility, if the resident uses the wheelchair for self-mobility and is not exclusively transported by others using a wheelchair, that's what the definition of wheelchair mobility is all about. So transport does not count. We have another question. How about boots, heel protectors, and splints for GG dressing? Just a reminder, the items associated with dressing include things like elastic bandages, elastic stockings, or orthoses. So a splint would be considered an orthosis, boots would be considered shoes, and heel protectors, I'm not quite familiar. I might suggest that I have orthotics on the shoes that I'm not wearing today, and I would consider those to be heel protectors without further definition from the questioner about what they mean by heel protectors. Roll left to right during toileting. Is that bed mobility? Is that self-care? How do we code the rolling left to right during toileting? Roll left and right is associated with a mobility activity, rolling left, right to back. And toileting hygiene is the ability to manage perineal hygiene and clothing before and after having a bowel movement. I see them as two distinct activities. Would you agree?
So I guess if somebody is mostly bedbound and if somebody is incontinent, let's say, and so the toileting hygiene is being done in bed and they are being rolled, if 2 people are required to help manage the clothing, you would code that as 1. So if in the event that toileting hygiene is happening in the bed, maybe that was the example, you would take into account everything that happens to get the pants or whatever the person's wearing, to pull those down, the hygiene, and pulling them back up. So if that involves rolling the person over and it takes 2 people, then you would code that as dependent. So I hope that helps.
Thanks, Anne.
So we should probably go to Sherry.
Okay, please.
Do you want?
Nope.
Okay.
Please.
All right, I want to be sure we hear a little bit about share your action plan ideas. We have about 5 minutes left. So I think those will get shared momentarily. Great. Okay, so thank you, Alice, so much. And thank you for all your questions. These are actually really helpful to hear what your questions are, so thank you. Thank you, Alice and Casey, for doing that while I was just up here. Okay, so just to go through a few of these. Plan to retrain both nursing and therapy services on Section GG, terrific. As I think all of you have heard, these will be available on YouTube in the near future. on the CMS channel. Also plan to train both disciplines on QMs that have been affected by this section and how it affects APU. So terrific. So again, just to reinforce what Alice and Deb mentioned, there is an APU table that you can look at which items are affected by APU. The QM user's manual tells you how the quality measures are calculated. So those are two great resources for you as you do that training. Both disciplines need to have an understanding of this section as coded should collaborate the information from both. Absolutely, that is terrific. I know as a nurse, some of the best therapists that I worked with, I loved they used to come down at the end of the day, meet with me and the patient resident and basically say, this is what we worked on today, this is what this person should be working on tonight. And so everybody was on the same page. We kind of knew expectations. If the person wasn't doing as well that evening for whatever reason, I was providing the feedback the next day. So again, the collaboration, really, really wonderful. And again, goals co-created between the team of clinicians and the residents and their families is appropriate. I'll just read one more. Make sure if your therapy team is assessing these items as part of their evaluations that all the new items are added to their evaluation forms as part of the supporting documentation of section GG items. Terrific advice. What will I choose in prior device use if my patient uses cane? So so this is a question, that's fine. So if the person doesn't use a cane, or if the person uses a cane but none of the other activities, you check none of the above. So let's see, consider including this GG info on your nursing admit assessment, especially when you have medically compromised residents who won't be starting rehab in the first 3 days. So that's excellent advice. Direct care nurses will need to assess this information in the first 3 days of the stay. Don't assume rehab will do this. Okay. So I think with that, I know it is lunchtime, and so again, really appreciate your attention and all your fabulous questions. I really appreciate that engagement. Thank you.